This is the case review for a 72-year-old female with dyspnea and diaphoresis. So this 72-year-old woman, she's got shortness of breath. One thing right there I want to mention, dyspnea should be considered an angina equivalent, especially in patients who have atypical presentations. Your postmenopausal female has atypical presentation, so they might not have chest pain. Shortness of breath is a very common symptom with a myocardial infarction or any cardiac complaint. Along with that, she's alert and oriented with diaphoresis. Now, diaphoresis is another angina equivalent. If somebody's got profuse sweating, you should consider that to be equivalent to chest pain, like crushing chest pain. And when I say unexplained, what I mean is like they're not outside in the heat or they're not exerting themselves. They're just sitting there with diaphoresis. So that should be considered cardiac until proven otherwise. Along with that, she's got a history of hypertension and diabetes mellitus. So diabetes patients end up with neuropathy and they experience pain differently, and they can have an atypical presentation of a myocardial infarction as well. So although this patient doesn't have the voiced chief complaint of chest pain, she does have no equivalents: dyspnea, diaphoresis, and with a history of diabetes, you really have to have a high index of suspicion for a cardiac complaint. As you assess this patient further, you note she has labored respirations, about 24 breaths per minute, but she's working to, despite that, let's say she's got an O2 saturation of 95 to 99%. Her blood pressure is 154/92. Her pulse is about 64 beats per minute, and her GCS is 15. So with this information, what further assessments do you want to do? We said she's a diabetic. Let's say her glucose is normal as well. Of course, we want to get an EKG and a 12 lead, right? We said she's got dyspnea, she's a postmenopausal female. We should consider that an angina equivalent. She's got unexplained diaphoresis. We should consider that an angina equivalent. And she's got a history of diabetes. So she's got all kinds of reasons that she wouldn't present like a typical cardiac patient. So here's the 12 lead, okay? And we're going to assess this 12 lead. So I'm looking at it methodically. It looks like the leads are on appropriately, right? We always look at lead 1 to make sure the QRS is positive, and AVR to make sure it's negative, right? And that's just a quick check to make sure the limb leads are on appropriately. It doesn't mean that you couldn't have an axis deviation with the limb leads on correctly, but we always want to double check that. You have a narrow QRS complex, so there's no signs of an intraventricular conduction delay or a ventricular rhythm. And it looks as if we have a prolonged PR interval, right? So our PR interval is a little prolonged and it's consistent, right? So we'd call this a sinus rhythm with a first degree AV block. We're going to assess this rhythm, of course, further for any ST elevation or depression, right? And so a lot of people, when they look at this 12 lead, they identify ST elevation in lead 3, right? And it does look like maybe it's 0.5 millimeter elevated, if that. And that, while it doesn't meet your local STEMI guideline criteria, when it's proportionate to a very small QRS, right? So you have a very small QRS complex in lead 3. So any degree of elevation is pretty significant. And along with that, the two most reciprocal leads on a 12-lead EKG are lead 3 and AVL. So whenever you see a change in one of those, you should look at the other one. So let's look over at AVL, and it looks like we have that reciprocal like ST depression with an inverted T wave there. And again, it would be very minute ST depression, if any, 1/4 to 0.5 millimeter of ST depression, but also a very small QRS complex. And it doesn't look like we have any contiguous elevation. They're pretty isoelectric J points in leads 2 and AVL, which would be the other inferior leads. So it looks like the start of maybe an inferior wall MI. But what we're looking at here on this 12 lead, what we're looking for is actually going to be V2. I want you to look at V2, all right? So I'm going to zoom in there. And V2 is indicative of something else, not so much an inferior wall MI, sometimes associated with an inferior wall MI, but in this case, a posterior wall MI. V2 on most people has a slight degree of elevation, right? You definitely wouldn't see depression normally in V2. So the J point in V2 on this one looks slightly depressed, right? Which is abnormal. And it's flat. You have a flat ST segment, low voltage T wave, but you have that flat, slightly depressed ST segment there, which is abnormal. And it's very difficult to identify absent of anything else. But with the patient that's got no equivalence or even angina, and if you look at this 12 lead, you should be highly concerned about a possible posterior wall MI based on V2. Now, a lot of times you'll see the changes all the way from V1 through V3. All right. This patient in particular did go to a PCI center and they did get a cardiac cath, and the patient actually was diagnosed with a distal posterior descending artery occlusion. So let's talk a little bit about that. So here we're looking at the back of the heart, right? The posterior wall. We talk a lot about the front of the heart, the anterior wall, and the right ventricle and the left ventricle. So those coronary arteries actually continue around to the back. So the right coronary artery, which starts at the base of the aorta, and it goes around anteriorly in between the atria and the ventricle and that coronary sulcus. It wraps around, okay, and it goes to the posterior wall. And in about 80 to 85% of people, the right coronary artery actually provides blood flow to, this is called the posterior descending artery. The posterior descending artery. That's the coronary artery that provides blood flow to the back of the heart, okay? So the posterior descending artery, and that's the one that's occluded in this patient that we're talking about. So in about 85% of people, that comes from the RCA, or the right coronary artery, and we call it a dominant RCA if that's the case. So that's a normal situation. Sometimes the remaining people either have a dominant left circumflex, where the LCX or the circumflex will come around and provide blood flow to the posterior descending artery, or they can have a codominant or an anastomosis, where the circumflex and the right coronary artery would actually both connect in the back of the heart at that posterior descending artery and provide collateral blood flow from both of those, which would be probably the best case scenario, because then you can have a little bit of a backup. Here's another example of a posterior wall MI. This one, of course, is existing in the presence of an inferior wall MI, and this is a very common pattern, and I want to discuss this. Of course, you see an inferior wall MI with ST elevation, these flat, elevated ST segments in 2, 3, and AVF. All right, with, of course, reciprocal changes in AVL. It's very rare that you'll have an inferior wall MI without reciprocal changes in AVL. So if you ever see elevation in lead 3, you need to look over at AVL for that ST depression. And that's almost enough right there to say that this patient's having a STEMI. But here we see the posterior wall changes over in V1 through V3. All right, so you see ST depression over here in V1 or V2, V3, and even in V1. And it goes a little bit all the way over to V4, actually, a little bit of ST depression over there as well. Let me get everything out of the way here. All right, so you see your ST depression, as well as sometimes you'll see early R wave progression here. We have very tall R waves in V3. The normal transition is V3, V4. So those tall R waves in V1 and V2 that might occur could actually be posterior Q waves. You'd have to look at it flipped. So this ST depression in V1 and V2 is considered ST elevation posteriorly, right? So V1 and V2, those are your septal leads, but they are also showing you the reciprocal side of the posterior wall. A couple things to note about this EKG. So going back to the inferior changes in leads 2 and lead 3, if you ever see this where you have more elevation in lead 3 than in lead 2, that's a good indication, and it's almost conclusive that this is a right-sided MI. You actually don't even need to, if you do a right-sided 12 lead, if you see this change. And it's simply because of the vectors that the leads look at. Lead 3, it looks more to the heart, the right side of the heart, than lead 2. And if an inferior wall with elevation in lead 3 greater than lead 2 is very indicative of a right-sided MI. So that's a quick little trick there. A couple reasons you want to note these posterior wall changes, because this is obviously a STEMI, but let's say you had only the changes in V1 through V3 without the inferior wall MI. That might be indicative of the 12 lead that we started with, where it's just a distal occlusion of just the PDA, right? So if it's just a PDA occlusion, you might not get some of those inferior wall changes that will be a lot more obvious because they show up as elevation, where we would just be looking at ST depression. In that case, you might do a posterior 12 lead in order to get your STEMI criteria. One trick that's often taught to people is to get the 12 lead inverted and backwards. So if you flip these V1 through V3, so now you see V3 is up at the top, V2 still in the middle and the V1's down at the bottom, you'll see that the ST depression posteriorly is actually considered elevation. It would be pretty significant elevation, right? And any R wave would actually be a Q wave. So you'd see big Q in V3 and a little Q in V2. So that's what we're talking about. So some of those signs of a posterior wall MI are early R wave in V1 and V2, especially if that R wave is bigger than the S wave. You shouldn't see that normally. Obviously, the ST depression, and you could have T wave inversion. Any of those are good indications of a posterior wall MI. We talked briefly about a posterior 12 lead. So what does that mean? To get a posterior 12 lead, what you'll do is you'll take off the electrodes for V4, V5, and V6, and you're going to move them around to the patient's back. You're going to take V4 and put it in the posterior axillary line. So that's where the armpit kind of ends in the back. That would be your posterior axillary line. And what you're doing is you're continuing it at the same level pretty much as where V6 stopped. All right, so put V4 there, that's where you get V7. And then V5, you're going to move to the mid-scapular line, which would obviously be in the middle of the scapula there. And to find that, it's easy to do if you take the patient's left arm and you just raise it up as you're palpating their upper back. And you can find the scapula pretty easy that way. And then V6, you're going to want to move the paraspinal region, just medial of V8, okay? And that's going to be just outside the vertebrae there, paraspinal, and that'll give you V9. And those would be your posterior leads. And the reason we're moving 4, 5, and 6 is because we usually have changes, the reciprocal changes in V1, V2, V3. So if you move V4, V5, and V6, you can keep those reciprocal changes on the 12 lead, and you'll see the elevation in possibly V7, V8, or V9, giving you really clear STEMI criteria with that posterior 12 lead. So that's it. I hope you enjoyed this ECG case review of the 72-year-old female with dyspnea and diaphoresis.